In this section, we'll review the pharmacology of some of the common agents used for the treatment of stroke. I'll start off with a review of the pathophysiology of the two types of stroke that we'll discuss today, which are ischemic and hemorrhagic stroke. So hopefully by understanding what causes each of these types of strokes, the types of treatment that are recommended will make more sense. For each of the classes that are listed on this slide, I'll review the mechanism, the pharmacological effects, adverse effects, therapeutic uses, and precautions of these classes. As you'll note, some of the classes like fibrinolytics and antiplatelet agents were previously covered by Dr. Bassel, so I'll refer you back to his slides for a more comprehensive overview of the fibrinolytics and antiplatelet agents. Some definitions before we start. So you may have heard people refer to strokes also as TIAs. They're actually a little different. So transient ischemic attack, or a TIA, is when you have some sort of neurological deficit similar to a stroke, but it lasts for less than 24 hours. And this is because there's a temporary interruption of blood flow, but you don't actually have an infarction or cell death. Although the time limit is set less than 24 hours, typically it onsets very suddenly and it usually lasts for less than 15 minutes, but again, it can be up to 24 hours. The reason why we pay more attention to patients who've had TIAs is that it does increase your risk for having a stroke afterwards, particularly in the first 30 days after a TIA. About 15% of patients who've had a TIA will go on to have a stroke, and 12% will die within the first year. Stroke is what we're really going to spend all of our time on today, and this is now when you have a neurological deficit that lasts for greater than 24 hours, and this is because either from a clot, which is ischemic, or from bleeding, which is a hemorrhagic stroke, this leads to cell death in the brain. There are two different types of strokes that we'll discuss. Again, in this section, we'll focus on ischemic stroke. You can see it's much more common at 87%, and it's where a clot blocks blood flow to an area of the brain. The clot can either originate in the brain or migrate from a distant source, such as in patients with atrial fibrillation. Hemorrhagic stroke, you can see, is also much less common. It's only 13%, but the reason why we spend some time talking about it is it has a much higher rate of mortality, 2 to 6 times higher compared to ischemic stroke. And this is just like it sounds when bleeding occurs either inside or around the brain tissue, causing cell death and ischemia. So how do these patients present? You may have typically one side of the body affected with numbness or weakness. This can cause difficulty with coordination. Patients may have trouble speaking or understanding, and also sometimes trouble with their vision. One of the key things about ischemic stroke symptom onset is that the symptoms do come on very suddenly. 1 minute they're fine, the next minute they're having a lot of deficits. In the bottom left, you can see patients may also complain of a sudden severe headache with no known cause. You'll see when we get to hemorrhagic stroke later that this is more typically a symptom of hemorrhagic versus ischemic stroke. One of the biggest parts of stroke management is to quickly identify the type of stroke and treat it fast. The reason why is you have a core of ischemia, and this is the site in the brain that's directly downstream from the clot. So this is the area where you have cell death, and this is what's causing some of the neurological symptoms. Around the core area is something called the penumbra. This is an area of the brain that's marginally ischemic. It's still got some blood flow from collateral vessels that you can see here in the middle of the brain. But if you don't restore full blood flow to the penumbra, within about 2 to 3 hours, that area of the brain is also going to get ischemic and die too. And you can imagine that your stroke symptoms are going to be much bigger and your deficits much more severe. As we saw before, ischemic stroke is much more common of the two types of stroke, and these are caused when you have a blood clot that's blocking downstream flow to a part of the brain, as shown here. The clot itself can be one of two sources. One is a thrombus, and these are clots that originate near the site of the infarction, usually within the brain itself. The other type are embolus. These are clots that migrate from a distant source. So common causes of these would be patients with atrial fibrillation who may develop clots, or valvular disease, or coagulopathies. As far as the big picture treatment overview of ischemic stroke, of course you want to do general supportive care that you would provide for any patient in the hospital. Again, beyond the scope of this lecture, but just, common things like treating fever, keeping fluid and electrolytes intact, providing other supportive care as needed. So what do you do for the stroke itself? Well, again, these strokes are due to a clot that's blocking blood flow and causing ischemic effects. And we saw that if you can restore blood flow to the damaged areas, that can help minimize downstream neurological deficits. So the goal is to achieve reperfusion to the area or to restore blood flow as quickly as possible. And there's really only one medication that's been shown to do this safely and effectively, and that's one of the fibrinolytic agents called TPA or alteplase. Other things like mechanical interventions can also be completed at certain centers, but that's beyond the scope of this trial. For the long term, though, once a patient has had a stroke, about 25% of patients will actually have a recurrence. So trying to prevent future clots is really important. So we'll talk about some of the agents that you can use to, again, prevent clots in the future. And in another section, we'll discuss blood pressure management, as that's one of the risk factors for ischemic stroke. So now we'll move on to the treatment of ischemic stroke. When you think about what causes ischemic stroke, it's clots. So in our body, naturally, we have the coagulation cascade, and the mediating process for this is we have our own intrinsic fibrinolysis, which is the process by which the body breaks down clots. People also studied the use of thrombolytic agents, which essentially do fibrinolysis on their own. One of them is TPA or alteplase. A TPA is a serine protease that converts plasminogen to plasmin, and then plasmin is responsible for degrading fibrin, which is part of the clots. Other lytics have been studied for use in ischemic stroke, but none of them have had positive outcomes like alteplases. They've actually just increased the risk of bleeding. So only alteplase or TPA should be used for the treatment of ischemic stroke. Based on the mechanism of action, the main side effect of TPA or alteplase is bleeding, so patients have to be carefully screened for risk factors for bleeding before they receive TPA and followed up afterwards. So as I mentioned, there's really only one agent, TPA, for the acute treatment of stroke as far as medication goes. So a lot of the pharmacotherapy involved in stroke is actually related to secondary prevention. How do you prevent a stroke after that first event? So when you're thinking about secondary prevention, hopefully it makes sense that an antiplatelet agent, which would interfere with clot formation, would help prevent recurrence of stroke. And as Dr. Bassel discussed, there's several different types of antiplatelet agents that all work in different ways. Things like aspirin, dipyridamole, or the thienopyridines, which most commonly clopidogrel is used. All of these through different pathways are going to end up inhibiting platelet activation and aggregation, and so they've all been shown to be effective for decreasing recurrence of stroke. And for that reason, an antiplatelet agent is recommended in all patients who've had a non-cardioembolic ischemic stroke. That is a stroke not from something like AFib. As far as comparing the different agents, aspirin's usually the preferred first line, just because it has the most studies behind it, the longest experience, and it's cheap and affordable. However, the other agents are equally effective. So what about anticoagulant agents such as warfarin? If you recall from Dr. Bassel's lecture, warfarin works by blocking vitamin K epoxide reductase, and this is the enzyme that's responsible for converting vitamin K into the reduced form, which can then interact with the gamma-glutamyl carboxylase to activate certain clotting factors, which are 2, 7, 9, and 10. So with warfarin on board, it's going to block this pathway, so you get decreased production of your clotting factors and decreased clot production as well. So they've looked at the use of warfarin in stroke, and what they found that if you have patients with embolic ischemic stroke, so say strokes due to something like atrial fibrillation, paroxysmal AFib, that warfarin is actually superior to the antiplatelet agents. So for that reason, warfarin is recommended for embolic ischemic stroke prophylaxis. You shouldn't use it in patients who have non-embolic stroke. In this case, it just increases the risk of bleeds without reducing stroke occurrence. As Dr. Bassel probably mentioned, warfarin is a difficult agent to use. There's a lot of drug interactions, patient response is very variable, diet interactions as well. So it's not the easiest agent for patients to take or to achieve the control that you want. So with all of the difficulties that warfarin presents, the release of some of the newer oral anticoagulant agents, or the NOACs, created a lot of interest. These are agents that work in different places in the clotting cascade. Factor Xa inhibitors are rivaroxaban, apixaban, and the newest one is edoxaban. There's also, farther downstream, dabigatran, which acts as a thrombin inhibitor. These agents have all been indicated for stroke prophylaxis in patients with non-valvular AFib. And as far as efficacy goes, warfarin and apixaban probably have the strongest evidence as far as stroke prevention, but the guidelines in general recommend to consider other things like patient preference as far as dosing frequency. Some of these agents are once a day versus twice a day. Cost and insurance coverage is probably one of the bigger issues, and just availability for adherence and follow-up. So again, for all of these agents, the fibrinolytics, the antiplatelets, and anticoagulants, I'll refer you back to Dr. Bassel's lectures for more details about the pharmacology.